welcome to UCT's Africa Virtual ENT. We apologize for the technical delay. This morning, we're very pleased to introduce you to one of our guest speakers, Dr. Mughal, who's a resident from Aga Khan University Hospital, and she'll be presenting today. We look forward to your presentation. Thank you.
Good morning, everyone. Good morning, everyone. My name is Dr. Ainulakbar, and I'm from Aga Khan University, Karachi, and I was here for my clinical attachment. Thank you very much for giving me the opportunity for this presentation today. So today I'll be discussing one of the study from back home, which we did at our center, and then we will be talking a little bit about thyroid, the management of thyroid nodules. So first thing first, there's nothing to disclose. Thyroid nodule is a common pathological entity that is found globally in almost 1/5 of the population. Among those which have a thyroid nodules, the malignancy rate ranges from 7 to 15%. The management depends upon the diagnosis, and usually the surgical intervention that is done is a thyroid lobectomy, which means you take out half of the thyroid out, or total thyroidectomy. The complications include recurrent laryngeal nerve paralysis, dysphagia, dysphonia, seroma formation, a hematoma, or hypoparathyroidism, which means low calcium levels postoperatively. Initially, because of we are talking about very, very early days of surgical interventions, the thyroid was known to have a very high morbidity and mortality rates. Traditionally, it is being done as an inpatient surgery everywhere, at most of the places. And the recommendation of it being an inpatient surgery are due to management of a drain, which is present in the neck, risk of hematoma, risk of hypocalcemia, and other complications. According to a study, which was the consensus statement, which was published in 2018 by ATA, the average inpatient duration for thyroidectomy was 5 to 9 days, and for lobectomy, it was 3 to 5 days. At our center, the usual inpatient duration of patient after thyroidectomy would be 4 to 6 days, and for lobectomy, it would be 2 to 3 days. But now, after the introduction of T. Cocker's meticulous surgical techniques in the start of 20th century and the progression in the development of safer general anesthesia techniques, thyroidectomy has evolved into a surgical procedure with low morbidity and low mortality rates. So it is termed to be a safe. According to British Association of Endocrine and Thyroid Surgeons, they report morbidity rate of 0.2 to 7%, and Lombardi et al. Reported complication rate of 1 to 5% only. So in 2013, American Association of Thyroid, ATA, published a consensus statement on patients who are safe to undergo thyroidectomy as a daycare procedure. They were talking about thyroidectomy as like thyroid lobectomy as well as total thyroidectomies. So they gave an eligibility criteria for thyroidectomy. So all the patients who were ASA 1, 2, or 3, they had a primary caregiver which was willing and available at home to take care of the patient postoperatively. The social setting was safe for postoperative management, and they would live in proximity to a skilled hospital facility were termed eligible for a daycare thyroidectomy. Patients who had cardiac, pulmonary, or renal diseases with dialysis dependence or were ASA 4, the patients who had visual or speech impairment or seizure disorder, patients on anticoagulant or antiplatelet therapy, patients with massive goiter or locally very advanced cancer, patients who had lack of transportation or used to live at a distance from a hospital facility, and who had a challenging hemostasis during surgery were termed not eligible for daycare thyroidectomy. So advantages of daycare thyroidectomy includes decreased risk of infection, especially in the COVID era, which struck us all, reduction in the charges, and reduced burden on healthcare system. In US, approximately $2,500 are saved from health budget per patient if the per year if the patients are done as a daycare in terms of thyroidectomy. At our center, almost a difference of 1 lakh rupee per patient is there if the patient is planned for a daycare thyroidectomy, and readmission rate according to ATA were 0 to 1.6% only. So now we come to our objective. So our objective of this study was to assess the feasibility and safety of thyroid lobectomy only as a daycare surgery and its effect in decreasing overall financial burden on the hospital. It was a retrospective and prospective chart review, which was done from 2006 to 2022 after ERC approval. Patients undergoing daycare thyroid lobectomy were recruited. Out of 1,624 patients which were done during this period, 156 patients, the thyroid lobectomies were done as a daycare procedure. 115 were in retrospective arm and 41 in a prospective arm. So all ASA 1, 2, 3. So we stick to the ATA eligibility and non-eligibility criteria for the inclusion and exclusion for our study. Talking about the results, mean age of our patients which underwent thyroidectomy was 39.2, and the oldest patient we operated on was 80 years old, and the youngest was 12-year-old. The frequency of Bethesda category on the preoperative FNAC, most of the patients had Bethesda 2. We will be discussing the Bethesda category. So Bethesda 2 means benign. So 59% of the nodules were benign, followed by Bethesda 3, which were 22%, and Bethesda 1, which was 12%. Majority of our patients stayed from 2 to 4 hours in the hospital, which were 137 patients. Only 1 patient left the hospital within 2 hours of the surgery. 8 patients stayed in the hospital for 4 to 6 hours, and more than 6 patients and 10 patients stayed in the hospital after more than 6 hours after the surgery. Drain was placed in only 12% of the patients, and 88% of the patients after thyroid lobectomy, drain was not placed. And in those patients, the drain was placed. It was removed on day 1 or day 2. On the clinic, we called them in our clinic, and drain was removed there. The complications which we encountered, so conversion to inpatient, 5 among our cohort of 156, only 5 patients were converted to inpatient, and among those 5 patients, 1 patient was scared to go home, and for 4 patients, the insurance company did not allow them to have a daycare thyroid surgery covered with their insurance, so that's why they converted their daycare procedure plan to inpatient. Only 1 patient developed seroma on day 7, and which was drained in clinic, and he never had any other complication. There were no ER visits from our cohort. So to conclude, in our cohort, minimal post-operative complications were reported, and thyroid lobectomy appears to be safe as a daycare procedure. Talking about the strength and limitations of my study, it was a retrospective and prospective data. It has a strong clinical relevance, and it's first of its kind in our country, and especially it can be clinically implicated in countries with limited financial resources. Our sample size is small. It's a single-center study, and that's why it cannot be generalized into non-tertiary care setups. So now we'll talk about the thyroid gland. It's a little bit. So I stick to recommendation. So the recent recommendation from American Thyroid Association. There are certain recommendations about the evaluation, the diagnosis, and the management. If we will go through the paper, I can share that that article with all of you. It's a very good article to read through. I have just handpicked a few of the recommendations by them, and have planned to just give you a little gist of the thyroid diseases after the discussion with the other registrars. So The thyroid gland is the largest endocrine gland in the body and also the one with most commonly encountered malignancies. The incidence of thyroid cancer is substantially increased over the last few decades due to increase in use of neck ultrasound, picking up the nodules in the thyroid, basically. So thyroid nodule is a discrete lesion within the thyroid gland, which is radiologically distinct from the surrounding thyroid parenchyma. It may be palpable or it might not be palpable clinically and might just be an incidental finding. It could be benign or it could be malignant. So non-palpable thyroid nodules detecting on ultrasound or other images are termed incidentally discovered nodules or incidentallomas. 7 to 15, the malignancy rate is almost 7 to 15%, and it has an excellent long-term survival. In patients with papillary thyroid cancer, we can say that the 5-year survival rate can go as high as 96%. But as in case of anaplastic thyroid cancer, the survival rate is hardly 20%. The prevalence of palpable thyroid nodules is higher in females, as compared to males. But usually the males are the one with malignant thyroid nodules. In females, mostly we encounter benign thyroid nodules. So if we are ever suspecting a thyroid malignancy in a patient, the patient usually has history of prior exposure to radiation or family history is positive for thyroid malignancy. There is a rapid nodular growth. The patient can present with hoarseness or pain in the neck. It's for examination. You always examine the thyroid gland itself. We assess and document the vocal cord status preoperatively. We must comment on the cervical lymphadenopathy, and we should look for fixation of the nodule to surrounding tissues, because usually the benign nodules are not fixed to the surrounding tissues like sternocleidomastoid or skin or the mandible. So this is the recommendation. So everything which will be in a box will be a recommendation by ATA. So this is every thyroid nodule that is reported to a physician should undergo thyroid ultrasound with either suspected or known thyroid nodules. So thyroid ultrasound can answer, is there truly a nodule, the size of the nodule, and the pattern or echogenicity of the nodule. We are always able to answer on lymphadenopathy, and we can comment that is the nodule solid or it's a cystic one, and where is the nodule exactly located. And we can always comment on parathyroid and vocal cord function on ultrasound as well. So as in our setup, the ultrasounds are inexpensive as compared to CT or MRI. So we never go for a CT or MRI for a thyroid nodule, and they can be done in ENT clinic by an ENT person. The features which are consistent with thyroid cancer are microcalcification, hypoechoic nodules, nodules with irregular margins, or nodules which are taller than wider. So if an ultrasound has certain suspicious feature, we always go for FNAC of that thyroid nodule to diagnose. And FNAC, and how do we know that we should go for FNAC of this particular thyroid nodule or not? For that, a thyroid classification is proposed. So for thyroid classification, there are certain ultrasound features which are scored, and on the scoring, if there is so for composition, if the nodule is cystic, spongiform, mixed cystic and solid, or solid. So you give points for each of the composition. You comment on echogenicity, you comment on shape, you comment on margin, and you comment on the echogenic foci which are present in the thyroid nodule. Then we add all the points and calculate our thyroid score. If there is thyroid 1 or thyroid 2, we never go for an FNA. In case of thyroid 3, if the size of the nodule is more than 2.5 centimeter, we will go for FNA. If it's less than 1.5 centimeter, again, we will just follow the nodule with regular 6-monthly ultrasound. If there is a thyroid 4 or thyroid 5, then we will go for an FNA. I hope the chart will help you guys. Okay. So after FNA is done, initially there was a lot of issues because every histopathologist would report the FNA according to the visible features. Then Bethesda gave a classification. So there's Bethesda system of of reporting the thyroid, the cytopathology is start from bet 1 to bet 3. So bet 1 means the specimen is unsatisfactory or non-diagnostic, and it has a malignancy rate of almost 1 to 4%. Bet 2 means the lesion is benign with the malignancy rate of almost 0 to 3%. Bet 3 means atypia of undetermined significance with malignancy rate of 5 to 15%. Bet 4 means that it is follicular neoplasm or suspicion for a follicular neoplasm with malignancy rate of 15 to 30%. Bet 5 means there's the lesion is suspicious for malignancy with 60 to 75% malignancy rate. And bet 6 means the lesion is definitely malignant with the malignancy rate of 97 to 99%. So if we start talking about thyroid cancers, there are follicular-derived thyroid cancer and neuroendocrine cell-derived thyroid cancer. The follicular-derived thyroid cancers are differentiated thyroid carcinoma, poorly differentiated carcinoma, and undifferentiated carcinoma. And neuroendocrine are medullary thyroid carcinoma. So talking about the DTCs, we have papillary, follicular, and Hurthle cell neoplasms. The initial therapy goals for any cancer of thyroid is removal of primary tumor, minimizing the risk of recurrence and metastasis, minimize the treatment-related morbidity, facilitate post-operative radioactive iodine, and permit the accurate staging and risk stratification. So if there is a follicular-derived cell neoplasm, the recommendations from ATA are if any thyroid cancer is more than 4 centimeters, there is gross extrathyroidal extension, metastasis of neck node, and distant metastasis, we should always go with the total thyroidectomy with removal of all the gross tumor available, including the neck dissection. If the thyroid cancer is more than 1 centimeter, less than 4 centimeters, there is no extrathyroid extension, no metastatic neck nodes, no distal mets, we should go for total thyroidectomy. Or if the patient is low risk, we can go with lobectomy and have a good surveillance. If thyroid cancer is less than 1 centimeter, thyroid lobectomy can be done. Unless there is some indication for total thyroidectomy, because keeping patient on a thyroxine for a longer period of time is also very hassle. Previously, the guidelines used to say that every differentiated thyroid carcinoma more than 1 centimeter should go for total thyroidectomy. But the revised guidelines are embarking on unilateral thyroidectomy because there is very selective approach to radioactive iodine now. So this is the criteria for, so it calls AIMS risk stratification criteria for high risk or low risk, and only the high risk patients presented are given the radioactive iodine post-operatively. So what are the indications of the post-operative post-operative radioaction? Any papillary thyroid cancer which is more than 4 centimeters, if there is extrathyroidal extension which is gross, and clinically or regional distant metastasis are there, a patient's age is more than 45, there is a contralateral thyroid nodules, means bilateral thyroid lobes have nodules, and there is history of radiation to head and neck, and it's a familial DTC, you should always go for an upfront total thyroidectomy because the post-operative radioactive iodine will be indicated. When would you do a lymph node dissection? So it recommends that clinically involved central neck nodes, you should always go for a therapeutic central compartment neck dissection. If there is a PT3 or T4 or PT3 with any N1B disease, prophylactic central compartment neck dissection should be done. And if there is a T1 or T2 thyroid cancer, neck dissection is usually not advised. If there is a biopsy-proven metastatic lateral cervical lymphadenopathy, because sometimes the papillary thyroid carcinoma is only detected because patient will not present with the thyroid nodule. Patient usually present with the neck node, and that is found to have a papillary thyroid carcinoma. Then you should always go for a therapeutic lateral and central compartment neck dissections. Because of shortage of time, I will skip through this. This slide is particularly for the risks. The surgeon should communicate the surgical risks, injury to the nerve and parathyroid tissue with patient before the surgery. The discussion should include the potential for temporary or permanent nerve injury, sequelae of nerve injuries, hypoparathyroidism, bleeding, scarring, recurrence, need of thyroxine post-operatively, and surgeon's own rates of complication should be discussed always. How would you assess the voice? So preoperative voice assessment must be done as a part of preoperative physical examination, including patient's description of vocal changes as well as physician's assessment of voice. Laryngeal exam should be performed in all patients if there is a preoperative voice abnormality, history of cervical or upper chest surgery, or known thyroid cancer with posterior extrathyroid extension or excessive nodal nets. Voice alteration is an important complication, and voice assessment alone may not identify chronic nerve palsy, so laryngeal exam should always be done. So when preoperatively you would suspect, if the patient is presenting to your clinic, but the voice is fine, but how would you suspect and counsel more about a nerve injury? If there is a voice abnormality, dysphagia, airway symptoms, or prior surgery in the neck. If on examination there is an extensive firm mass with fixation to larynx or fixation to trachea. If on imaging on your ultrasound mass is extending beyond thyroid, it's infiltrating into the trachea or esophageal, or there is a bulky cervical lymph node, the patient has a higher chances of laryngeal nerve dysfunction. So ATA recommends that visually identifying the laryngeal nerve during the dissection is required, and the parathyroid gland in their blood supply should be preserved during thyroid surgery. This was a study which compared the outcomes of permanent and transient nerve palsies in comparison with visual identification only and with nerve monitoring intraoperatively. And there was the results showed that there was not in a long-term follow-up, there was no difference in the permanent paralysis or transient paralysis in nerve monitoring versus visual identification. So nerve monitoring in every case is never advised. So let's talk about the TNM of thyroid cancer. So T2 is any tumor that there is no evidence of primary tumor. T1 is split into two. T1A, if any tumor less than or equal to 1 centimeter in greatest dimension limited to thyroid gland. T1B, that the tumor is more than 1 centimeter, but less than or equal to 2 centimeter limited to thyroid again. T2 is any tumor more than 4, but less than or equal to 4 centimeter limited to the thyroid gland. T3A is any tumor which is more than 4 centimeter, again limited to thyroid. T3B is any tumor with gross extrathyroid extension involving the strap muscles only from the tumor of any size. T4A is gross extrathyroid invasion invading the subcutaneous tissue, the larynx, trachea, esophagus, or recurrent laryngeal nerve by tumor of any size. T4B is any thyroid tumor with encasement of carotid, involvement of mediastinal vessels or prevertebral fascia. So N0A means one or more cytologically or histologically confirmed benign lymph nodes. N0B, that there is no radiological or clinical evidence of locoregional lymph node metastasis. N1A, that the metastasis is to level 6. N1B, metastasis to unilateral, bilateral, or contralateral lymph nodes. So in GTC, the staging of the tumor stage 1 if the patient is less than 55 years of age, and stage 2 if there is distant metastasis only. And if the age is more than 55, only then the staging is like T1 and T2 are stage 1. T1, T2, T3 with N1 and N1 in case of T1 and T2, stage 2. Any T4A tumor is a stage 3, and T4B tumors without metastasis are stage 4A. The tumor is only stage 4B whenever we have a distant metastasis, and this is showing that the patients have a better prognosis with differentiated thyroid cancers. Thank you so much. I'm open for any questions.
Thank you very much. Yeah. So for you see patients from rural areas, you can see again follow.
No, so the patients which are from rural areas at our place, we at least follow them for first year. So after surgery, the patient can go home, or we can arrange their accommodation near our hospital. There are certain places, and the patient will follow us after 10 to 14 days with their histopathology report with us, and we give them plan. If there is a radioactive iodine, if they have cancer, then the RAIs are present, and only then with a plan of how should they proceed with their RAI, they are sent back to their home.
Yeah, but what I'm getting at is Have you seen the African Head and Neck Society guidelines?
I have,
Yeah.
got it, yeah.
Yeah, so what I'm getting at is, I think it's quite dangerous to simply apply the American guidelines to our setting.
Yeah.
Because we've got a patient who can't come for follow-up.
Yeah.
Patient who can't be monitored for hypoglycemia or hypothyroidism.
Yeah.
Can't access a replacement therapy. What do you do with those patients?
Yeah.
Do you just follow the American guidelines, or do you?
No,
do you
obviously,
adapt them?
no, we adapt them, we don't follow them all blindly. So we adapt them according to the patient, according to the available resources. For example, as per ATA, post-operatively, you should regularly check calcium, regularly check thyroxine, go for TGs and everything. We can't do that because we have limited financial resources. So for example, post-operatively, the calcium is only monitored once post-operatively on 48 after 48 hours. And only if there is a drop, then we regularly follow them for calcium, otherwise we don't. And if we do partial thyroid, if we do a thyroid lobectomy, we never check for TSH post-operatively regularly. We only follow TSH if their patient had total thyroidectomy and not on 6 month interval, on 1 year interval. So we have adapted them, not like just.
When you know that about 25% of patients become hypothyroid after thyroidectomy.
Yeah.
So you don't monitor those patients.
We only monitor in thyroid lobectomy. We do TSH if there is some clinical indication. If they are like if the history is giving us suspicion that they will be developing hypothyroidism. Otherwise.
Yeah, because you're starting a study now with the group in Harvard.
Okay.
And you can look at whether I can just do just take out a thyroid module as opposed to the unique thyroid.
Hemithyroid. Okay.
Because we become far more conservative with pulmonary carcinomas and anybody, and so if you've got a good ultrasound that shows there's no other nodules in the thyroid node,
Yeah.
why take out the whole thyroid node?
Yeah.
And so that study being designed now.
Okay.
See whether we become more conservative.
Excellent.
Yeah. And then you can just go back to your thyroid classification slide.
Yeah, sure.
I just want to see there because you've got your greater and lesser than. I think it might be the next step in this correctly.
Okay.
Thyroids. Just keep going back. Yeah, there. So you say there. Thyroid's 4.
Yeah.
Follow up if it's more than 1 centimeter, should be less than 1 centimeter.
Okay.
Am I right?
Yes, there's a mistake there.
That's right, you must strip it
Yeah,
out. Yeah. And then keep.
And even in thyroid 5 follow up, if it's less than 0.5.
Yeah, thyroid 3 should also be less.
Yeah, it just like the rapid
Yeah. Are there any other comments?
Any comments from the floor? Well, thank you very much, Anne. That was a very informative, concise and thorough presentation. Hope everyone has a good day.
Thank you very much.
Thank you.
Yeah.